Our presenter today for our Tuesday teleconference is Matt Wenger, and Matt found his passion in nursing when he started his practice in the adult med-surg ICU at Royal Alexandra Hospital in Edmonton in 2011. Matt's commitment to professional development is evident in his most recent unit-based initiative, which involved creating an antibiotic parenteral administration guide while he was working in the med-surg ICU at the Health Sciences Center here in St. John's. And it was this tool that really spurred his interest in antimicrobial management with the emerging resistance seen today in practice areas. Fortunately or unfortunately, Matt did move from St. John's in August and is currently in Calgary. He's working at the bedside in ICU and CCU at the South Health campus. Matt's a member of the Canadian Association of Critical Care Nurses, and he most recently spoke at the National Dynamics of Critical Care Conference in Toronto. He was also the recipient of the 2017 Canadian Association of Critical Care Nurses Chasing Excellence Award in Toronto. You may recall from September Access magazine that Matt was featured in the Goings On section of the magazine in reference to his award from the Canadian Association of Critical Care Nurses. And although he isn't currently in our province, he has agreed to share this information provincially because it's certainly the information related to antimicrobial stewardship knows no boundaries. So Matt, I will turn it over to you for your presentation.
Thank you so much. And yeah, like Siobhan said, this topic is quite important, and I believe next week is Antimicrobial Stewardship Awareness Week. So there are a number of different Twitter handles and online resources that either your provincial regulatory body can provide or even through CNA. So I encourage everybody to look at that. Today, on this first slide here, exploring the key role nurses play in antimicrobial stewardship. And on the next slide, I have no disclosures. I'm not being paid by anybody, or I'm not being funded by any antibiotic company. So the overview for today, we're going to talk about antimicrobial resistance, antimicrobial stewardship, the nursing role in antimicrobial stewardship, and then discuss that ICU or critical care quick reference guide that I had created with the help of my fellow colleagues, pharmacists and educators. Also the fear now to undertreat and overtreat, and we will get into that topic. And again, the Choosing Wisely campaign. So what is antimicrobial resistance? So of the many bacteria that surround us, very few are actually resistant. Some bacteria are good and some are bad. Antibiotics destroy both the good bacteria and the bacteria that cause illness. But however, the remaining bacteria that are there are now resistant and can now proliferate and take over. So how does that impact us? It poses a huge threat to patient safety worldwide. Current conditions have been deemed as a perfect storm that relate to the widespread of antibiotic use alongside a decrease in the number of new antibiotics produced by pharmaceutical companies. The perfect storm has also been created by the spread of these resistant organisms and with current access to international travel. The resistance results in increased mortality and morbidity, increased hospital stays and associated costs. And a researcher in 2016 found that greater than 2 million people develop serious infections with bacteria that are resistant to greater than one antibiotic, and they lead to about 23,000 deaths per year. And this was a study from the United States. So a question then, what are some common antimicrobial resistant strains we see in Canada? So on the unit in our inpatient hospitals, acute care settings, we see MRSA, C. diff, CRE, carbapenem-resistant Enterobacteriaceae, and we also see vancomycin-resistant Enterococci, or VRE. There are also various other bugs, of course, too, but those are some of the more common ones. So there have been worldwide initiatives that have been started to combat the issue of antimicrobial resistance. This includes the Longitude Prize out of the United Kingdom, and the Longitude Prize was based on the 1714 Longitude Act. And this act at that time, in 1714, it helped ships navigate the globe safely and increase trade amongst nations during that time period. However, the funding organization for the Longitude Prize took that same concept, something innovative, and their focus today is on antibiotics. So today the prize is worth 10 million euro and is open to researchers and scientists to find new ways of combating antimicrobial resistance. And it has an informative approach of bringing awareness to the issue. So there are three methods that bacteria use to resist antibiotics. And with the format of this presentation, there was a quick video. It may translate over onto the online slides, but we won't be able to share that today. It's just a quick definitional video. And the three ways that bacteria use to resist antibiotics include their efflux pump. They neutralize the bacteria, so they bring in, neutralize the antibiotic, and they bring in that antibiotic and they dissolve it. And then number three, they either take that antibiotic and they modify their own components of their cellular structure, or they modify the antibiotic components of the compound itself. So from Brunning in 2014, who's referenced the Longitude Prize, bacteria themselves can be divided into two broad classes. We know gram-positive and gram-negative. The classes derive these names from the Gram test, which involves the addition of a violet dye to bacteria, if you can recall from maybe junior high or elementary days science experiment. Gram-negative bacteria are more resistant to antibiotics. Gram-negative bacteria are more resistant to antibodies, and antibiotics than gram-positive bacteria, because gram-negative bacteria have a largely impermeable cell wall. The bacteria responsible for MRSA is an example of a gram-positive bacteria, while those responsible for Lyme disease and pneumonia are examples of gram-negative bacteria. And so the Longitude organization, they listed the top 10 most dangerous and antibiotic-resistant bacteria. And with the next slide, I've shown all 10 of them there. And with the transition on the slide, I've ordered them 1 through 10, but we'll just go through, say, the top 5 here. And so for the longer exposure to antibiotics, these opportunistic bacteria are subject to, the greater pressure these bacteria have to select the resistance. So the more antibiotics that are given to these bacteria, the longer they have a chance to modify themselves to become resistant. So these resistant strains are transmitted between asymptomatic carriers rather than people with disease. So that's often a common misconception that these resistant strains are only transmitted to people who are showing signs and symptoms. However, many of us are asymptomatic carriers and can spread the infection a lot quicker because we don't show the signs and symptoms of these resistant strains. And then just going through the list here, so number 5, we won't go through all 10, but number 5 was Klebsiella pneumonia. It's associated with lung infection and often associated with weakened immune systems. Number 4, we know well, in the hospital setting and in the community, I'm sure. Clostridium difficile. It causes diarrhea, and it has a consistent presentation worldwide. It is one of the better known superbugs because of its presence in the hospitals, and it's easily spread through contact with spores or contaminated surfaces, and it presents with complications in the colon. Number 3, Pseudomonas aeruginosa. This was first documented in 1872. It causes pneumonia and a variety of other infections. Its resistance is medium in its ability, and its virulence is quite worrying. It's described as an opportunistic infection because it primarily affects humans that are already critically ill and can cause serious complications with people with cancer or cystic fibrosis. Number 2 is one, after now presenting this at Dynamics and talking with colleagues, I was not familiar with this bug, but it's Burkholderia cepaceae, and it was first found in 1949 or looked up in 1949, and its illness cause is pneumonia. Its antibiotic resistance, however, is quite low, and its virulence is worrying. So I'm not too sure if this is something we've seen here in Canada, but it was the number 2 spot. And it mostly affects people with pre-existing lung conditions such as cystic fibrosis. And number 1, one of the top 10 most dangerous and antibiotic-resistant bacteria is our friend Staphylococcus aureus, or MRSA. And it was first documented in 1884. The illnesses it causes is pneumonia. It's also responsible for flesh-eating disease. Its antibiotic resistance is medium, and its virulence is quite dangerous. We know that this superbug is very easily spread through human contact and can cause a range of illnesses from skin disorders to deadly diseases like meningitis and pneumonia. And it's most often treated with penicillin type of antibiotic or family of antibiotics. And we know a large portion of our population come into the hospital with penicillin type allergies. And this can be an issue because this is one of the main antibiotics used to combat this infection. However, hand hygiene is the most positive way to mitigate this MRSA spread. So that's our best bet to combating this number 1 antibiotic-resistant organism. So from the compound interest study group here in 2014, they just summarized for us different classes of antibiotics. So ranging from beta-lactams discovered in 1928 to lipopeptides discovered in 1987. So a wide range of antibiotics and the timeline there. We won't go through all of them, but 2 modes of action. So lime green, or green on your slide there, is bacteriostatic. So these antibiotics, they resist growth and reproduction of the organism. And the blue or aquamarine color on the slide there in their figure, these are bactericidal. And so they cause bacterial cell death and eliminate the organism. So I've included a little comic strip here from Cyanide and Happiness, and it's C. diff tricking the individual there to give them more antibiotics. So just a little comic relief for the presentation for this very serious topic. The group from Tama et al. In 2017, they took a look at the association of adverse events with antibiotic use in hospitalized patients. So there are adverse drug events such as allergy reactions and organ toxic effects. subsequent infection with antibiotic-resistant organisms, including C. diff infections. So from their study, 27% of the antibiotics received were for UTIs, skin and soft tissue infections, and community-acquired pneumonia. Of the 324 antibiotic adverse events, 314 of them were considered clinically significant in the way of either a new hospitalization, either prolonged hospital stay, also with the additional visit to a clinic or emergency room visit, and then also clinically significant in the way of additional laboratory tests such as ECG for prolonged rhythm changes and imaging such as chest x-rays. So adverse drug events can lead to antibiotic-resistant organisms, which ultimately contributes to the risk for increased costs, which decreases revenue and lost productivity, and a greater association with disability and death compared to infections that are easily mitigated by conventional antibiotic treatment. So the importance of antimicrobial stewardship, and the group Olands, and Witt in 2017 said, successful stewardship depends on nurses' ongoing vigilance. And I think this is very true. So antimicrobial stewardship has been curated over the past 16 years in the literature in the form of structured models and advisory committees. And in the absence of new drugs, stewardship programs have been established to improve the way currently available antibiotics are used in hospitals. Antimicrobial stewardship guides prudent use of antimicrobials to combat resistance through the use of advisory panels, education, and drug utilization strategies. Stewardship optimizes treatment by guiding the type of antibiotic used, the dose, the duration, and the route of administration. Antimicrobial agents that are selected are as specific as possible, and the course of antibiotics are being stopped as early as possible, and there is the talk of also switching them from an IV administration source to PO or orally when appropriate. This helps to reduce the number of adverse events, and stewardship activities also have recommended that some antibiotics should be avoided within the hospital setting. So careful selection of antibiotic therapy, along with appropriate duration, has been shown to slow the emergence of resistant organisms. So stewardship-focused activities include on patient admission with their clinical progress, following patient safety data, and then following up with the patient upon discharge. So who are the key stakeholders in antimicrobial stewardship? Well, it's a multidisciplinary approach. The literature has often cited this team to include clinical microbiologists, pharmacists, infectious disease specialists, and Eastern Health has an antimicrobial stewardship committee, and it involves medicine, pharmacy, microbiology, public health, infection prevention, and control. So what about antimicrobial stewardship and nurses? The formal stewardship programs reviewed in the literature have little to no mention of nurses' participation in stewardship initiatives. The group in Olands et al. In 2016 found that only 11 articles out of 900 made mention of nursing participation in antimicrobial stewardship. This is a 1.2% presence in the reviewed literature, which is extremely poor. So nurses' role in antimicrobial stewardship has been underexplored. However, nurses have the most consistent presence and are the most proximal when involved with patient care. and it is imperative to have nurses involved in the discussions revolving around antimicrobial stewardship. So why are we not mentioned when nurses are a natural match to antimicrobial stewardship programs and our daily tasks are inherent in stewardship activities? So how do antimicrobial stewardship models align with our nursing activities? So from that same author, Olands et al. In 2016, nurses are antibiotic first responders. We are the central communicators, coordinators of care, as well as 24-hour monitors of patient status, safety, and response to antibiotic therapy. Nursing is therefore at the hub of communication among all antimicrobial stewardship participants. Our role as nurses is essential to interdisciplinary communication. In 2016, the Gallup poll in the United States ranked nurses the most trusted profession based on honesty and ethics 15 years running. The nurse's presence is represented in the hospital, in the home, and in the community. And in each of those three areas, nurses are natural educators, advocates, and ambassadors for widespread behavioral change through more vigilant antibiotic awareness. So as you can see, patient and family are obviously quite central, and the nurse, as the nurse, registered nurse, LPN, we are surrounding that patient with our care and helping them get through that illness stage. And at the center of this, we are part of those antimicrobial stewardship activities, coordinating all of the other services to optimize patient care. So the American Nurses Association put out a white paper, and it was titled Redefining the Antibiotic Stewardship Team. And from the figure above, it says it demonstrates the position of the nurse with the patient and the family, and that we are the hub among all of the stakeholders in antibiotic use. So the critical role of the staff nurse in antimicrobial stewardship is unrecognized, but already there. So what are kind of 5 areas we can focus on, or that they highlighted? So patient admission. So we are there as nurses with triage with appropriate isolation on admission, review of allergy history. We can start early and appropriate cultures as ordered by the physician team. We are there to initiate timely antibiotics, and we are there to review patients' previous medical reconciliation or history. Number 2, daily clinical progress monitoring. So again, we monitor the progress of the patient, and that includes reporting of vital signs and accurate charting. Patient response to treatment to detect a superinfection or drug-resistant infection. And then we'll go through the microbiology data and the preliminary test results, and we can bring this forward on patient rounds to possibly suggest or initiate antibiotic adjustment. Number 3, patient safety and quality monitoring. So this includes adverse events, change in patient condition, reviewing those final culture results from the lab, and then therefore changing antibiotics or adjusting them according to those final cultures. And then also being aware of antibiotic resistance identification. And number 4, clinical progress, patient education, patient discharge. So nurses are there to help along with this process. So at least in the critical care setting, antibiotics are most effective in the form of IV, and a lot of the times that patient population, their GI tract is very hypoperfused or not active enough to withstand absorption. So PO, switching from IV to PO, is not always an option within the critical care setting. However, the literature suggests that IV to PO antibiotic switch has also been shown to reduce antibiotic resistance. So in the inpatient setting, or maybe on discharge, or maybe in the outpatient setting, or even in the community, having that switch over to an oral route has been shown to be beneficial. And this is even related to the reducing the amount of IV access. Another invasive line, even a peripheral IV, can spur a new infection. So I think the oral route is beneficial. Again, with that clinical progress, patient education, and patient discharge, we are there to provide education. And it's even been demonstrated that nurses in the community who are even part of the vaccination campaigns, especially this fall with the flu vaccination campaign, we can provide that extra education not only on the topic of vaccination, but on topics such as antibiotic therapy, resistant therapy, and other topics that, say, the client or the patient has questions with. So we are out there providing that educational piece. We can supervise outpatient antibiotic therapy. We can address the length of stay for an individual within the hospital. And then we can supervise long-term care management and a patient's readmission status. So it all comes down to infection prevention and control. So hand hygiene compliance. And again, this is from a critical care focus, but it doesn't stop at the doors of ICU. This can apply to most settings, and hand hygiene applies to all settings. So antimicrobial stewardship extends into infection and prevention and control with hospital-acquired infections. Infection and prevention protocols are reliant on nurses' participation in hand hygiene initiatives, which has been demonstrated as a simple and effective measure at controlling the spread of infection. Nurses can be positive infection control advocates when modeling appropriate contact precautions, educating both the isolated patient and their families and visitors, while appropriately identifying barriers to non-compliance. And nurses have been extremely successful at implementing catheter-associated urinary tract infection bundles, so minimizing UTI infections. And then also the central line associated bloodstream infection bundles. So within the critical care setting, or those individuals with a central line out on the ward, such as a PIC, these bundles help us mitigate signs and symptoms of infection at those central access points. And then this will just allow us to assess the patient's risk for infection with these invasive lines. And from the study of Kurtz 2017, with the image on the slide, so when hand hygiene non-compliance was observed, the reason was documented. So nearly 20% of missed opportunities were accounted for by 4 activities, and they included, number 1, carrying something, even as small as a syringe or a 4x4. So that object in your hand occupied your ability to carry out hand hygiene. So that was at 9%. Donning gloves or PPE. So that was 6%. Again, just another step that may have interrupted hand hygiene processes. Pushing or pulling a workstation, a bedside table, something that is part of your daily care, that was 2%. And then more common, 1%, using a mobile device. Now, sometimes that may include a hospital mobile device. Lots of hospitals are becoming on board with hospital Wi-Fi, iPads, etc., that can document patient care activities. But this also includes our own device that we may or may not carry with us. And so the high performers in the study were asked to explain why their compliance for hand hygiene was so prevalent, and 4 themes emerged. These individuals had internalized standard precautions in their practice. They had experienced a previous exposure and were determined to not allow it to occur again. And unfortunately, I haven't encountered this in my experience within Eastern Health or Alberta Health Services or while I worked in Ottawa, but bonuses and pay raises were linked to compliance. I wish that was a Canadian, I wish this was a Canadian study. And then number 4, the individual, and mostly a female-dominated profession, pregnancy and concern for their unborn child was a big factor for high compliance with hand hygiene. So Bauer et al. In 2017 produced a large meta-analysis, and they revealed the impact of antimicrobial stewardship programs on resistance. So when antimicrobial stewardship is combined with infection control measures, it is more effective than antimicrobial stewardship alone. So it's this combination effect. So we have infection control plus effective hand hygiene plus antimicrobial stewardship initiatives. And in their study, this equaled a decreased rate of MRSA and antibiotic-resistant gram-negative bacteria, as well as ESBL, or extended spectrum beta-lactamase producing bacteria, and CRE, carbapenem-resistant negative bacteria, and C. diff. So with those 3 activities combined, had a global reduction in these resistant strains within the areas that they were studying. Antimicrobial stewardship activities include antibiotic cycling audits and antibiotic restriction to be the most effective. So nurses and antimicrobial stewardship. So nurses need adequate training and education on relevant antimicrobial topics to support nursing tasks. So information such as protocols, instructions, references should be geared to practical tasks for administering antibiotics. Technology or e-health or continuing education models can help support this initiative within the clinical setting. And these education focuses could include online learning modules, integrated displays in the care setting to showcase protocol-based information, and the use of online resources such as Micromedics, which is an IV-based compatibility resource. So it's all about coordinating and enhancing collaboration between the disciplines as we can help to enhance antimicrobial stewardship efficacy. Nurses in the study by Mostagman et al. In 2017 felt the top 3 forms of support from the antimicrobial stewardship team to include the positive information of updates and continued education, the expert contacts and mentors, and they also valued protected teaching time. So the goal here of antimicrobial stewardship programs is not to have nurses become prescribers of antibiotics, but rather to recognize and utilize the established nursing functions to optimize antimicrobial stewardship programs, goals, and cost-saving outcomes. And Edwards et al. In 2011 said, prescribing and management of antibiotics occurs across all areas of healthcare and does not sit within a particular specialty, and this can impact organizational memory of the health authority. And I love this term, organizational memory. It is the retrievable information contained within an organization in formats such as spreadsheets and guidelines, as well as the mind of its staff. So nurses, we represent a static profession within the hospital, and we are in an ideal position to contribute to the total organizational memory relating to antibiotic management. The literature also suggests you change the terms from antimicrobial prescribing to the term antimicrobial management under stewardship initiatives. It's a more inclusive approach. It provides a holistic mindset to involve everyone in the organization to decrease antimicrobial resistance and to increase antimicrobial stewardship involvement. So, nursing role in antimicrobial stewardship. So what are some things we can do in your practice? What are some 5 key strategies? So antimicrobial stewardship should not be viewed as yet another job to be saddled on the backs of nurses already burdened with other interdisciplinary efforts. Nurses should view antimicrobial stewardship as a way to better understand the proper use of antibiotics. The nursing role also positions nurses to be at the center of and facilitators of communication among all participants in stewardship programs. So the 5 key strategies. Number 1, correct antibiotic information. So these are things that we can do today, and this was presented in American Nurse Today online magazine. So number 1, ensure information pertaining to the antibiotic is available at the point of care. So we have to ask ourselves, why was this treatment initiated and how long is the antibiotic duration? Number 2, correct antibiotic administration route. So based on those microbiology reports, your sputum sample, your urine culture, your blood cultures, make sure that we are matching the correct antibiotic to those results. And again, as I had mentioned earlier, switching over from IV to oral antibiotics have been deemed beneficial, and it's related to decreased hospital stay and decreased IV infection. Number 3, reassess the antibiotic therapy continuously. So we should be doing this in a 2 to 3 day time frame. This engages in the conversation of the antibiotic timeout and to review that appropriate therapy. And then, so for example, we have a patient who is newly admitted. We know there are signs and symptoms of infection or sepsis. And so we put them on a broad spectrum antibiotic such as piperacillin, tazobactam. However, as the culture results come back to tell us what type of bug it is, these 2 to 3 day time frame antibiotic timeouts allow us to reassess and allow us to have that target antibiotic narrowed down to something a little bit more specific. Number 4, we have reviewing of that antibiotic therapy. And so this magazine article said when we review the antibiotic therapy, we should really be careful when we suspect or send off samples for a new acquired C. diff infection. And greater than 90% of C. diff occurs following or during treatment with antibiotics. And the majority of the population who acquire this superbug is the elderly. So the question we should be asking ourselves when we do send off these samples or we come in contact with patients with C. diff is, can some of the current antibiotics be stopped, or can we look at changing them to combat this infection? And number 5, antibiotic reconciliation. So these are all at points of transition. This includes change of shift, a point of transition between nurses, between charge nurses. That handover piece is so imperative in patient safety and reconciling what medications are being delivered. Again, updating that patient Cardex ensuring that all the relevant information is present, and referring back to progress notes and the chart. And also, points of transition would include patient transfer to other units. So either from emergency to an inpatient bed, from ICU to an inpatient bed to a long-term care facility, or an outpatient clinic. So those points of transition are quite vital in making sure that we don't miss anything and we're able to hone in and make sure that the appropriate treatment is being delivered. So the ICU, or Intensive Care Unit Quick Reference Guide, it's a quick clinical resource. It's evidence-based. It was a collaborative project, and I was able to, while working within Eastern Health, distribute it between St. Clair's at the Health Science Center campus, and then I believe it was also brought out to the bedside in Carbonear. I wasn't able to confirm that, but I think that was the anticipation for the reference guide. So Lewis et al. In 2009 said the highest incidence of medication errors occurred during the administration of antibiotics. So this antibiotic quick reference guide helps increase the organizational memory in the ICU related to the administration of IV antibiotics. And this identifies a bit of a knowledge gap, just that extra source of information. However, it does have a bit of a limitation, I would admit, since it is a paper copy and it was updated on the most current IV parenteral drug manual and the knowledge from our ICU pharmacist. It is a very static document, whereas other online resources are continually being updated. However, the information on administration remains relatively the same, and I do believe that this reference guide is a good starting point for the conversation in helping nurses at the bedside have a quick reference on how to deliver that antibiotic in appropriate and timely manner. So this is just the example here. I just took a quick snapshot. So the ICU quick reference guide shows 26 common antibiotics used at the Health Science Center ICU. And it was implemented in November 2016, so about this time last year. It's a bedside resource and provides valuable up-to-date antibiotic administration information relating to appropriate IV fluid and compatibility, IV rate for both central or peripheral access with its appropriate concentration. And again, like I had mentioned, I had worked closely with the ICU clinical educators and pharmacists and the nursing professional practice. And yeah, we were able to distribute this to the 34 critical care bed spaces at the Health Science Center Hospital in St. John's. And we're excited that it was put at the bed space, and even talking with my colleagues, it helped the newer staff that were just joining the ICU. They were able to access that piece of information, but it also helped my senior staff members and staff members that have been in critical care for quite some time, and they were also able to readily use the information. And this type of information should never be memorized. Yes, you become familiar with practices in your daily routine, but when it comes to information such as how many grams and how many milliliters over how many minutes, I think this type of information should be readily available at our fingertips and should never be memorized, because that's how mistakes occur if the facts get kind of mixed up. So this is at every bedside table in the nursing resource binder. So the fear to undertreat or overtreat. So has the antibiotic course had its day? So Llewellyn et al. In 2017 came out with a study, and they had looked at limited evidence to suggest that stopping treatment early contributes to antibiotic resistance. And in their study, they kind of reinforced the replacement of complete your course of antibiotics with exactly as prescribed. And there needs to be more evidence to support the limited duration of antibiotic trials. So they note that the World Health Organization Antibiotic Awareness Week in 2016 suggested that always complete the full prescription, even if you feel better, because stopping treatment early promotes the growth of drug-resistant bacteria. However, there is no evidence to support stopping treatment early equals antibiotic resistance. So while taking antibiotic resistance for a longer than indicated duration also increases resistance. So if you stop it early or you take it longer than you need to, resistance can prevail. So that new message is complete the course with exactly as prescribed. And that is based on the type of organism being treated and how your prescriber feels the course should be taken. So this antibiotic course ignores the fact that patients may respond differently to the same antibiotic. Antibiotic duration is based on poor evidence, and the fear to undertreat versus overtreat is there, and its evidence-based research in this area has not been fully appreciated, and the trial design is difficult to implement. So completing the course goes against one of the most fundamental and widespread medication beliefs people have. And the public education should focus on the fact that viral infections do not require antibiotic treatment and antibiotic overuse and can lead to resistance, and it is not prevented from completing a full course of pills or antibiotic treatment. So again, that same author group, Olands et al., however, in 2017, they noted antibiotics were reassuring, soothing physicians' anxiety, and meeting patients' expectations. However, thus, the broad-spectrum antibiotics became the easiest choice when treating patients who had just about any condition. And these three posters here are from the Newfoundland Provincial Choosing Wisely campaign. And these campaigns, this Choosing Wisely campaign is nationwide, but the Newfoundland campaign has ramped up, and it advocates for properly using antibiotics for what they are intended for to decrease impending resistance. And the left poster there and the middle are educational campaign posters. But the far right poster, which I fell in love with, and on the transition of the slide, it just makes it a little bit further, but you can easily find this online as well. But it's the practitioner prescription pad. So for the nurse practitioners out there in primary care or the general physician practitioners out there in the community clinics, this prescription pad distinguishes between viruses and bacterial infections in layman's terms. It provides symptom relief management. It also gives you a timeline of illness or worsening symptoms to be aware of, and gives communication strategies for patients to ensure their care is tailored to them. And it's signed by the doctor or the nurse practitioner. And so a lot of individuals were going into their walk-in clinics or their family physician or their family clinic to combat the sniffles or that nagging cough or a bit of chest congestion, all related or possibly related to maybe something viral or not deemed appropriate for antibiotic therapy. And a lot of us just like the group from Olanzadel, feel soothed or listened to when we walk out of that clinic with a prescription in hand. However, this piece of paper fills that gap. It is still a prescription. It is still doctor's advice or practitioner advice to go home and kind of just take care of yourself in the common cold methods. So I found it very beneficial. This was a fantastic idea from the Newfoundland campaign, Choosing Wisely campaign. And from the presentation that I attended earlier in the spring at the Health Science Center, the uptake of this prescription pad varies across the province. Some clinics, they said some clinics had ordered boxes and boxes because they had gone through all of their supply quite readily, and then other prescribers did not feel this aligned with their clinic or how they wanted to practice, so they never did use the prescription pad. So it's part of the overall uptake of that practitioner and whether they want to use it or not. But I think, at least in the public sense or for the public, I think it's beneficial. Just kind of reiterates the need or lack of need for antibiotics for every illness or presentation of the sniffles or the common viral cold. So final thoughts. We've defined antimicrobial resistance and antimicrobial stewardship. We've acknowledged the role nurses play as key stakeholders in antimicrobial stewardship, and we know engagement is key. We are a large component of the hospital's organizational memory, and we've identified some strategies to promote stewardship initiatives. And so part of the questions that could be taking part this afternoon here, so what does antimicrobial stewardship look like in your area of practice? Or have you thought about it? Or is this something you've considered? And yeah, I think this is a good starting point or initial dialogue as we move forward, as resistance becomes more prevalent in our daily practice, and we need to get antibiotic use at a targeted level and make sure that we don't spread resistance. And I think nurses are a key component in that.